My name is Richard Newcomb. I'm a bone marrow transplant physician at Mass General Hospital. Our manuscript, Coping in Patients with Hematologic Malignancies Undergoing Hematopoietic Cell Transplantation, was a cross-sectional analysis of a multi-site randomized controlled trial. The randomized controlled trial was looking at the integration of palliative care during transplant hospitalization and looking at outcomes associated with that. And those results were initially presented at ASH by Dr. El-Jawari, and subsequent analyses will be presented at Tandem upcoming in February in San Antonio in just a few weeks. But this was a cross-sectional analysis of this study, of the baseline data. And this data was collected at Mass General, Fred Hutch, and Duke Cancer Center. So it's a relatively large data set. We have about just over 300 patients that are included in this data set, and we wanted to see how is our patients' coping skills that they have before they come into hospitalization, are those coping skills associated with quality of life and markers of psychological distress, namely symptoms of anxiety and depression and PTSD. And then finally, we wanted to see if there were clinical or sociodemographic factors that were associated with pre-transplant hospitalization coping. And just as background, coping, patients can cope in many different ways, and we sort of bucket those into approach-oriented coping. So those would be examples such as seeking emotional support, practicing acceptance, practicing reframing, actively coping with something, or avoidant coping, which can be things such as practicing self-blame, practicing denial, or disengaging from whatever is in front of you, or behavioral disengagement. So throughout this paper, we sort of use those two things as buckets, as approach-oriented coping or avoidant coping. And so the first thing we really did was just show that patients really do truly use a variety of these coping mechanisms. Over 60% of patients practice emotional support at high levels, as well as practicing things like acceptance. And then avoiding coping was also fairly common. Nearly a third of patients practice self-blame, and just under a third, about 31%, use behaviors such as denial. And what was interesting is that many patients are using more than one approach-oriented coping technique, and about 25% of patients, or about 20 to 25% of patients, are using more than one avoidant coping. And then about 10% of patients actually use both. So they use both approach-oriented and avoidant coping. And so it's actually quite, I think, a little difficult to put people necessarily into a bucket to say you're somebody who uses approach-oriented coping or avoidant coping, at least prior to hospitalization. Consistent with our hypotheses, we found that approach-oriented coping was associated with pre-transplant higher quality of life and lower symptoms of depression and anxiety. There was a signal toward decreased symptoms of PTSD, though that was not statistically significant. On the other hand, avoidant coping was higher use of avoidant coping was associated with decreased quality of life, more symptoms of depression, anxiety, and post-traumatic stress disorder, or PTSD. And those were true when we controlled for clinical and sociodemographic characteristics that could be associated with these patient-reported outcomes. Interestingly, in the patients that used both approach and avoidant-oriented coping, the signal toward increased distress was still present. So it seems that using avoidant coping is potentially a marker for increased risk of things such as psychological distress. In the final thing that we did was we tried to tease apart, were there factors that were significantly associated with pre-transplant avoidant coping. And the things that we found were that age and higher income were protective against the use of avoidant coping, and female gender and being on disability prior to transplant were associated with higher use of avoidant coping. So in future studies, we need to look at longitudinal assessment of coping after transplant hospitalization and figure out interventions to support approach-oriented coping and mitigate avoidant coping, as that can have the potential to improve quality of life and reduce psychological distress. And I think our conclusions were that prior to transplant, patients again employ approach-oriented coping, and a large minority relied on avoidant coping. And so suggesting that screening for coping strategy used prior to transplant could be very informative. Age, gender, and employment status were associated with avoidant coping, and that use of these coping strategies were strongly associated with baseline quality of life and psychological distress. I think there are multiple roles for us in that. I think before transplant, we spend a lot of time talking to people about things of what to expect, how well the transplant's going to work, what are the things to look out for. And I think trying as much as possible to relate that to somebody's experience is important. And so one thing I try to do is really just establish that transplant hospitalization is definitely a difficult process, both one with physical and psychological symptoms. And I try to prepare patients for that ahead of time. It is hard to completely prepare somebody. I find that patients, for instance, who have already gone through induction therapy with acute myeloid leukemia, they sort of already have a sense of what's like that, because there are many similarities to the induction hospitalization. But so particularly, I've tried to focus on those patients who may be chemotherapy naive, or who received less intensive chemotherapy prior to stem cell transplantation. The other thing I would say is that there's a role in the inpatient side of when patients are going through transplant to normalize feeling unwell and separating that feeling of that unwell feeling, whether it be physical or psychological, from any sense that the transplant is or isn't going well. I think I find that this is, again, a clinical sense that when patients feel unwell, they may assume that means that the transplant is not going well, when in fact these are often expected toxicities, physical or psychological, that we have people experience. So I think that's like one thing from just a pure education perspective. And the second thing I would say is that many patients have gone through hard things in the past, and people's one thing that's interesting about age being associated with less use of avoidant coping is I do think there's a signal there that patients have a wealth of experiences that they can draw upon. And I think our older patients just happen to have more of those experiences just accumulated over life. But I think that there is a lesson there in terms of how we prepare people to deal with the adversities of transplant. We can have them reflect on the difficult things they've been through in the past, so they can draw on those as a strength and figure out how to move forward. So I think that would be the other piece that I find as an extrapolation from this data and my own clinical experience.